We shall now go on to our next speaker, Dr. Shreya Shah, who's a senior consultant, Drashti Netralia Dahur, an amazingly prolific surgeon, and she's going to talk on a complex topic, managing strabismus post-orbital trauma. On to you.
Yeah, thank you so much, Dr. Chitra ma'am, for allowing me to speak on managing the strabismus post-orbital trauma. Out of our 12,687, nearly 14.16% were having orbital and adnexal injuries presented published in archives and graph archives and IGO. If you look at the traumatic strabismus, can happen with any of the structure, but mainly we're talking about the extraocular muscle here only. If you look at the trauma and strabismus, there are many ways the strabismus can happen, but we'll talk about only muscle injury in this talk. What can happen to muscle when it is injured? It can be contused, it can be partially lacerated, it can be completely lacerated, it can be snapped or pulled into two. It can be there can be a traumatic disinsertion of muscle, there can be muscle loss. If you look at the incarceration or entrapment, that can happen with blowout fracture with two different theories, and there can be one or more, two more muscle can be entrapped. If we talk about blowout fracture, can be pure and impure. Most of the blowout fracture, what we see is floor fracture, and this is a type 1 antral fracture when the elevation deficit is there. Is the type 2 antral fracture when the depression deficit is there, and type 3 antral fracture when both the deficit can be seen. But be aware of this white eye blowout fracture, which needs early and immediate repair because there is a trapdoor. What 8th thing happened to the muscle is flap tear, and 9th is slip muscle. So how to diagnose what has happened to muscle? Proper history taking, method of injury, objective of injury, general condition, facial asymmetry, subconjunctival hemorrhage, motility disorder, everything we need to take care, including by binocular single vision, diplopia charting, inophthalmos measurement, exophthalmos measurement. Once we do everything, we order for diagnosis. As a radiological investigation, ultrasonography, CT mainly, coronal, MRI with fat suppression, dynamic MRI with suppression coil is the best, or EMG, and we have to order for very thin cut. We have to be aware that in children there will be a trapdoor fracture, and in adult there will be open door fracture. MRI, we can reveal the muscle hematoma or contusion very nicely. Once we have done radiological investigation, ocular motility test, FDT and FGT will give you very good diagnostic tool. Ocular motility should be done for elevation, depression, abduction, everything, covered test, and saccades should be seen. Next is force duction test. Here the force duction test for elevation is positive. Force duction test for depression is definitely negative. But if you look at again doing force generation test for elevation, you can feel the tug. So there is some contractibility. If the child is too cooperative, we can do with Q-tip also. Here also we are checking force duction test for middle rectus. Suspected middle rectus entrapment is there. It is quite positive. Force duction test for adduction is negative, and at the same time force generation test for the abduction is positive. There is contractibility of medial rectus. So we have developed our diagnosis algorithm on clinical base. When there is blowout fracture with big defect, there can show not much of the motility disturbance. FDT can be negative, FGT can be positive. Blowout fracture with small defect with incarceration of muscle may show restriction in both the field, more in the opposite field. FDT can be positive, FGT can be positive. Trapdoor fracture may show markedly disturbance in the opposite direction and may be associated with bradycardia, vomiting, or syncope due to ocular cardiac reflex. FDT can be strongly positive. When you suspect flap tear, usually produce limitation of the movement in field of the muscle of action of muscle. FDT may be positive, FGT positive. Snapped or must pulled into show limitation in the field of action. Full movement in opposite direction. FDT can be negative, FGT can be positive. Contusion of muscle can show marked limitation of all action just because of edema and pain. Partial laceration may show limited action in field of action. FDT can be negative, FGT can be positive. Complete laceration of the muscle may show limitation in the field of along with the good movement in opposite direction. FDT negative, FGT can be positive, and complete insertion of muscle will give very good movement in opposite direction and no movement in the field of action. FDT can be negative, FGT can be strongly positive, and there can be any combination. Let's look into management. Until and unless there is a red flag signs like ocular cardiac reflex, retrobulbar hemorrhage, open globe injury, CSF leak, muscle strangulation, we don't operate. We don't jump to operate. We can wait. While we are waiting for 7 days or 1 week, we have to look for the improvement in ocular movement, orbital displacement, or development of enophthalmos. Sometimes we may have to prescribe prism or occlusion. So look one by one. When there is a muscle contusion, simple observation or anti-inflammatory will resolve and complete restoration of movement. Sometimes we have to support with steroid. Sometimes we may have a Brown's syndrome with the trauma, but if it is inflammation at trochlea, even anti-inflammatory will subside. If you look at partial laceration of muscle, usually 2 ends of the muscle can be seen. We can suture it back. But if it is long-standing, we may have to associate it with the resection of the same muscle or weakening of the antagonist when there is contracture. This is a complete laceration of muscle. This person was hit by stone, and once the muscle go, it doesn't go anywhere else other than its muscle sheet. So try to trace the intermuscular, trace the intermuscular septum. I'm so sorry. Try to trace the intermuscular septum where you can find the muscle here. The advantage is we can see some attachment date. So it was very easy to get this muscle. So this is a next day post-op, and we can got the good adduction. This person was hit by iron rod, and his inferior rectus was pulled in 2. It was snap muscle. So again, hook the adjacent muscle to observe properly, trace the intermuscular septum. Once you're able to trace the intermuscular septum and observe, it gives you very good vision, and then you can hold with non-traumatic forceps, and it's very easy to get the muscle. Once you get the muscle, you can suture it well. Once you suture, this is a 7th day post-operative, full movement can be done. This was already published. But sometimes we get old injuries, scar tissue, FDT positive, FGT mild positive, and there we have to order for thin cut CT, or sometimes we have to take help of EMG, attenuated sound. It is very old video. It is very difficult to find out the medial rectus muscle, which was already incarcerated, but still we could find the muscle seat and some fibers of muscle. So once you get this, you can fix it back to the insertion. So here we don't expect much of a movement, much of the adduction, that we can take care of the antagonist muscle also. Sometimes we are not able to find the stump. We have to transpose the muscle, or tethering the muscle can be done. And trapped muscle should be operated as fast as possible. There are so many indications of surgery like enophthalmos or ocular cardiac reflex. If we are not doing immediately, 7 days we can wait to subside the edema. The aim of surgery is permanently close the defect and get the full movement. The routes of surgery can be transconjunctival, transcutaneous, endonasal, and there are many orbital implants available which you can use of your choice. Nowadays, PLA, PGA, absorbable materials are available. So this 5-year boy was hit by ball. So we have done good orbitotomy. Once we are able to find out the defect in the bone, you have to take out all the incarcerated tissue and the muscle itself. Once you are properly taken out all the tissues, we can put polypropylene PPE implant, and we adhere with the tissue glove. And then later on, don't forget to do FDT at the end of surgery. The superior rectus also can be entrapped when there is a roof fracture. We have to take care immediately. There is an inferior rectus entrapment, and most of the people are saying that it's very less to damage the lateral orbital floor, but this lady has a lateral orbital hole and fracture, and then we had to take care. All the time you are not lucky enough to get only one muscle entrap. So we get the call from general surgeon also when they are operating for other kind of injury. So the same kind of general surgeon call I got, by the time he fixed it with maxillary things, then we did the inferior orbital rim fixation since it was impure fracture. Once it is done, then we can put the implant, titanium mesh implant, which can cover the medial wall defect as well as the inferior wall floor defect. Don't forget to do FDT. Even at the end of thing, you feel FDT is positive, again and again, go back and adjust the implant till the FDT is completely negative. Then only it is end of surgery. This is the picture of the same surgery. First day post-op, 7-day post-op. Can use the endonasal route also. Complication of orbitotomy can be many. I'll not discuss much of it here. Can be intraoperative, immediate, post-operative, late post-operative, or sometimes can be orbital compartmental syndrome.
10 minutes remaining.
The eighth thing is flap tear. So it is very difficult to get, but it's very interesting subject when the flap is already pulled from the muscle, and this is a MR flap. This flap can be a simple lamellar separation, or also there can be adhesion with the orbital tissue also. So there are 4 types of flap tear. Can be longitudinal flap tear. Again, can be too much or moderate longitudinal. There can be a beveled flap. There can be a lamellar flap, or then can be a retracted flap tear. So when there is a flap tear, you need to see from where the avulsion has happened. Here, the avulsion from insertion is happened, here from musculocutaneous junction, or here it's too posterior avulsion has happened. So this girl was hit by a stick and she was having a flap tear of inferior rectus. We found out and then we sutured it back. This is 1 day post-operative and then 7-day post-operative. This is today's picture only. Today only I got this person. I couldn't get the full video. At 5 only I have operated. Again, you can see this is a longitudinal flap tear and very thin part of sheet is seen here. So that you need to take care. Retracted flap tear also can be managed surgically. Last is the sleep muscle. Sleep muscle cannot go anywhere other than its muscle sheet. So just stress the muscle sheet and you can see very minutely observe, you'll see the muscle. Once you see the muscle, suture it back and attach it to the stump. There can be a iatrogenic loss of the iatrogenic damage. So this was a post-sinus surgery where the medial and lateral inferior rectus was adhere with each other. We operated, separated, then try to do the lead surgery also. Can be post-injection scarring, or sometimes patient is operated for just CCF and then that orbitotomy has caused strabismus that we need to take care later on. Once you do strabismus correction, only strabismus correction is not important. You need to take care of whole part, lead and medial canthus also. So I conclude with that. Weakening sometime overacting muscle of the affected side. If there is association palsy, strengthen the palsied muscle. Consider Farden to match the deficit of contralateral muscles also. So in last, I'll say that trauma to an extraocular muscle without globe or eyelid involvement is rare, but it can happen. Crucial information of management and CT, MRI or FDT, FGT knowledge can take you to the proper treatment. Even in COVID-19, we have done many repair because children staying home, they hit each other. These are my references. Thanks to my patients. Thanks to my teachers. Thank you all.
Thank you, Dr. Shreya, for a wonderful talk and a wonderful display of different kind of surgeries. A very simple question I'm going to ask before Kavita takes on. What are some clues which you could suggest for diagnosing orbital fractures in children?
Yeah, the diagnosis of orbital fracture, especially in children, it's proper history because they always hide from parents. They are so mischievous and they hide from parents. So once you tell the child to sit in the parent's lap and ask them to look up, and immediately you'll be able to see that whether the child is feeling dizzy or go in syncope, or sometimes may not go in syncope, but if there is there is a limitation elevation, you can definitely see there is a inferior rectus can be entrapped or cannot be entrapped. All the time we will not get the children who has got a mark on the body. So you have to look for the damage, and the earliest thing we had to take care. But in children, I usually try to use the polypropylene implant. Titanium mesh implant I use mainly in adult, and titanium mesh implant sometimes can give damage to the optic nerve. So you need to take care of that.
Thank you. Dr. Kavita?
Ma'am, amazing videos and amazing cases. I mean, most of us, we luckily have a very good ocular plan.
Thank you so much, ma'am. Thanks a lot.
Yeah. Ma'am, you said if they present early within a week, it's much easier to handle these kind of patients, but not all the time patients probably come like that, no? So what are the tips? What are the things that you would do if you patients present very late?
Yeah, so exactly, even if they present early, we wait for 7 days until and unless we don't expect any oculocardiac reflex or white eye blowout fracture. So 7 days as such, we wait for edema to subside. If they are coming later, then we have to take a help of our clinical motility test, ocular motility test, FDT, FGT, MRI and CT scan, or sometime EMG. So then you have to, as Dr. Rohit sir said, ASOCT also sometime, but we are not doing that in our tribal area. We are doing mainly MRI and CT based. FDT and FGT will tell you everything what you want to know about the thing. As I discuss all the diagnosis algorithm that can tell you so many things where the muscle is, with muscle is entrapped, or FGT will tell you you should go for surgery or you should directly take the patient as a spread of comitants in a fresh strabismus patient.
Shreya, actually your presentation was very good. Some
you.
points to ask, whether you do a surface coil, you have written that MRI with surface coil. Are you
Yeah.
using a surface coil, or it's just for the presentation you have put a surface coil?
I've just put the presentation because sitting in a rural area, it's not at all possible. We have to jump to the treatment. We cannot wait for everything, and we don't have availability here in a tribal area.
And second question is, if you have a patient with inferior trauma with inferior oblique involvement, where you
Yes.
have limited double depressor like palsy with a torsion, like
Yes.
an intorsion, because they'll not fuse unless they correct the intorsion. So how you treat those patients? Had you had any patients where there was an inferior oblique trauma with the inferior trauma? We had a patient, and patient had a hyper, and then you have a patient is not able to fuse because patient has got now torsion because intorsion is there. So how have you seen those type of patients, and how you have managed those patients?
Yeah. Some of the time we see that patient later on develop intorsion or extorsion when the oblique muscle are involved. So once you are taken care, all the muscles and everything is removed from incarceration and the muscles are free, we should treat the strabismus. After 3 months or 4 months, we should treat the strabismus as a fresh strabismus case, as we do in all transposition or recession of the antagonist muscle or tuck. Say ipsilateral muscle. So we should treat exactly as a fresh strabismus case. Once we are free, we know that it is already removed from incarceration, or if the FGT is negative, it is definitely a paralytic muscle. So treat as we are treating the paralytic things.
So what we did for our patient was
yes.
Because the patient had a lot of intorsion and patient had a hyper, so we did a inverse snaps procedure, and we did a anterior tinectomy of the superior oblique fibers. So that took care of the intorsion, and that because if you don't correct the torsion, they will not fuse. So we
Absolutely
have
right,
to take care of. So we took, and that flap tear also can cause. Ludwig was the person who described this flap tear, and the flap tear can cause both leash as well as reverse leash effect. So you will
where
have
it is attached at the anterior or posterior, leash and reverse leash can be presented.
So all trauma you should look for torsion and do a binocular feeds. Do you do binocular feeds?
Yes, sir, we do. And as you said that once once you suspect the intorsion or extorsion, and you have already said about the treatment as we do with the any other intorsion extorsion problem. Once the entrapment and everything is first thing is to remove entrapment or release the muscle from the bone, and then treat fresh patient. Treat as a fresh traumatic fresh strabismus patient, as we are discussing. All the speakers are discussing since 1 hour about how to treat paralytic third nerve palsy, fourth nerve palsy. So we can treat the same way.
And Shreya,
so I've not incorporated all the things.
So to
Shreya wants to
summarize
correct.
Dr. Shreya's point, so she says first we separate the orbital cause. We release the muscles and make sure the orbit is out of the equation. And once it is out of the equation, then you deal with the strabismus as we deal with any other strabismus. Right, ma'am?
True.
Yeah.
Yes, true, ma'am.
Yeah, so we
Shreya,
now
have you
So
tried
sometimes we
giving?
have to take support when there is lots of adhesion for flap. Sometime, very few time, one time only I've done, I take the help of amniotic membrane graft. We just wrap the muscle around the amniotic membrane and we separate the adhesion and scarring. That helps. And we
Have you
have some
tried?
things S9 sleeve available. Sorry, I don't have any other commercial things, but S9 sleeves are available, which is non-absorbable synthetic material that also we can wrap around the muscle. So that makes the movement free.
Have you tried Botox into the antagonist with the ruptured muscle?
Yeah, we can try, but here we have not tried. In our sitting, we are not doing. We are as soon as possible, if possible, we do operate, explore the muscle and release the thing. Unnecessary, we do not wait.
now
Thank you, ma'am.
there is a
Thank
lot
you so
to be
much.
learned, but we have to go on to our next speaker.
Thanks a lot, Chitra ma'am.
Thanks a lot,
Thanks
Shreya.
all
That was
the
amazing.
moderators. Thank you so much.